Good morning, everyone. Why don't we get started? Welcome. This is the HCBS Infrastructure Development Training. I am Carla Licio. I'm from Casa Columbia and MCTAC. MCTAC, as you know, is the Managed Care Technical Assistance Center, delivering training through webinars, live presentations, video, learning communities on all of the information that you need to know to navigate your way through healthcare reform. Casa Columbia is an addictions organization, and we are building a technical assistance center specifically for SUD providers. So you will be hearing more from Casa Columbia and what offerings we are developing. Couple of notes for today. I know this is a big, important issue. Lunch will be served. It will happen around 12:30. We're going to see how the training develops, what question and answer periods flesh out, but we will be breaking around 12:30 for lunch. Lunch will be out in the hallway. Will we be having a working lunch?
So it's people will get box lunches, they can bring them back in, and we'll have about half an hour in between, and then we'll go.
Okay, so box lunches, bring them back in. We'll have about half an hour, and then get right back to work. All of the slides that you see today, all of the material that you have will be available on the MCTAC website. In addition, we are being videotaped today, and that will be available also on the MCTAC website, and that will take about a month to get up and available. You have in front of you evaluations. I'm here to tell you that the doors will be locked at the end of the day, and you will not be allowed to leave until your eval is completed and handed in. Actually, thank you very much. We really appreciate those evals, and so please do take the time to fill them out. They're incredibly important to us. We need your feedback in order to better target the trainings in the future. So I really do appreciate your taking the time. And we will let you out, I promise. So let me get to the training. We are incredibly fortunate today. We have Josh and Megan, two fabulous presenters from Health Management Associates. Health Management Associates is a consulting firm specializing in the fields of health and behavioral health system restructuring, healthcare program development, health economics and finance, program evaluation, and data analysis. Extensive experience and expertise in the design and implementation of health and behavioral health programs, particularly with respect to system development, managed care, long-term care, and behavioral health care. To my left is Megan Schilke. Prior to joining HMA, Megan served as Chief Program Officer for Mental Health at the New York City Department of Health and Mental Hygiene, where she oversaw a $200 million portfolio of services and played a leadership role in Medicaid reform implementation. She has also served as Senior Advisor to the Executive Deputy Commissioner for Mental Hygiene and worked as a policy advocate for the Coalition of Behavioral Health Agencies. Next to Megan is Joshua Rubin. Prior to joining HMA, Josh was Vice President and Chief Operating Officer of the Mental Health Association of New York City, Director of Policy and Planning for YAI, and was Assistant Commissioner for Mental Hygiene Policy for the City of New York, Department of Health and Mental Hygiene. That's a long way of saying that Megan and Josh know what they're talking about. So I am going to hand this off now to Megan and Josh. I think today is going to be terrific, and thank you for being here.
Wow, thank you. Thank you, Carla, and that's quite an introduction. So good morning, everyone. We're really excited to be here today. Josh and I have been doing this training now. This is number 3. We've done a full day in New York City and also one in Syracuse in June. We are really excited to be here in Albany and really pleased to be talking with all of you about the incredibly important changes that are happening throughout New York State that will have great impact on your service delivery and the people that you serve. We're going to take a moment and go briefly through the goals of the training. Oh, I'm getting a little feedback. Is that because I'm close to this one? Do I need to? Okay, I'm used to moving around a lot during these, so if we get a little feedback, I'll try to adjust that. We're not used to necessarily being confined to a stage. We are usually out and about and walking and working with you, and this day is actually usually very interactive. We'd like to continue that with all of you, so we're going to need your participation. We have a number of exercises planned throughout the day where we'll actually be coming around and talking to you about your individual agency, about the issues that you're facing, and applying those to some exercises that we think will be useful for you to take back later to work with your staff and your board and your leadership around navigating these changes. So the goal of today's training, the goal is for you to walk out with something actionable. That's really, really important both to MCTAC, who has been driving these trainings around the state to try to meet your needs, but also really important to us. We want to make sure that when you leave here, you have some next steps that you're going to engage in at your individual programs. So if you have questions throughout the day, please don't hesitate to ask. You can ask us in between during breaks. You can just shout them out during the training, and we will address them at any point in the day that you have them, that they come up. I will also just briefly mention that the state has suggested that we remind folks, they've announced this, they don't have the actual application process yet available, but one of the upcoming opportunities that you'll all be eligible for, if you are a home and community-based service provider who has limited to no history billing Medicaid, there will be some transition and capital grants that you'll be eligible for. You'll have to submit a proposal to the state there, and they will be based on the fact on your limited history and also on your planning to date. You'll have to demonstrate a little bit that you've been working on some of these issues and planning around managed care implementation, and in particular talking with managed care companies, and are down the road towards eventually contracting with them for HCBS services. And if you can demonstrate those things, there will be limited transition and startup grants that the state offices are going to make available to HCBS services. So stay tuned for more information out of the State Office of Mental Health and Office of Alcoholism and Substance Abuse Services for those opportunities. So I mentioned that we like to be really interactive. There are also a number of materials on your table you should have in front of you. There's a booklet or a workbook that we distribute for each of these. Some of the more dense pieces of the material we've actually translated into a handout that you can walk out with. Also, your handouts for you to fill in during the exercises are included in that workbook. And additionally, what we had done previously is a summary of what was released in New York City as the request for qualifications to managed care organizations. Now, we realize, and hopefully you know this by now, that on July 3rd, just last week, the rest of state RFQ was released and is now available on the New York State Department of Health website, along with the draft rates. So if you have not already begun to review that, I highly suggest you check out, even if you don't read the whole thing, beginning to look at all the component parts of the RFQ, because this is the document that's going to guide which managed care organizations are qualified to cover HCBS services, to have HARP products and HARP plans, and to be qualified to manage behavioral health services in New York State. So please check those materials out. What we can do is, now that they've been uploaded to the state, when we distribute the PowerPoint, we can make sure the links to those documents are available through MCTAC. I'm going to jump right into the pre-screening results that you folks provided to us. We conduct, just as a preliminary assessment, a foundational assessment of where you are in your thinking and readiness as a group of providers. There are a couple of reasons we do this, and we know that many of you have been assessed to death. There have been assessments here and functional analyses here, and you've had to complete 1 million surveys, and you've had to fill all these things out. We really do use this to inform the things that we're going to emphasize today throughout the training. We also are using it as a way to monitor progress over time, because there are going to be future sessions you're going to be invited back to participate in. And MCTAC is very invested in making sure that there's progress being demonstrated as a result of these trainings towards readiness. So just really quick to cover the highlights of what we heard from you. Very few of you have been looking at the strategic plan and the 1915I services to date. Now, I understand that. Certainly, there have been a ton of variables and uncertainties so far, and we appreciate that. You may not have totally gone down that road. We're really hoping that today will help you jumpstart that process, and we're hoping that one of the things that will come out of today is that you'll feel comfortable initiating more of those planning activities. Very important, thinking about your revenue calculations. Now that rates have been published and you're able to begin to look at your budgets, we're going to talk more about financial analysis prospectively, but thinking about and beginning to really estimate what you think your future revenue might be. Capturing outcomes. You can see a little further up that some of you are already doing this. We know there are a number of programs that require it to date, but managed care is going to require it of all of you. So that's definitely on this list. Just take a moment, look at these, and sort of see where you are in relation to your colleagues. I don't know if there are any surprises here for some of you, but the thing that I was actually pleasantly surprised about was the fact that many of you have at least one contract in place. And so you've already begun some work or interaction, and maybe for services that you've been billing for historically, where you're already working with managed care organizations, but that's a really good foundation on which to build a lot of this. So hopefully that will help to inform our discussion today. So we're going to start today with a little bit of the big picture. Josh is going to talk about what's happening around the rest of the country, why this is happening to us, why this is happening to all of your organizations, how it fits in the larger national context of healthcare reform. We're going to talk about the foundational elements of managed care. These are the basic building blocks that you need to be very, very familiar with in order to be navigating this transition, including utilization management and level of care. We're going to talk a little bit about why managed care companies are doing the things that they're doing, their priorities. And we do work quite a bit with managed care organizations around the country, and we're able to gather some of that intel and to really distill it down for you into the key things that they need, because they have oversights too. Operations and infrastructure, we're going to go into a little bit into the finance and billing and revenue cycle management. We're going to talk about QI. We're going to talk about the IT underpinnings that you need in order to really begin to have sufficient infrastructure to do this, and how to build your value proposition. This is underlying the conversation that you will be having with managed care and payers for a very long time in the future. And then we're going to break for lunch, and we're going to talk about, okay, here are all the things that we've said that you need that are really important to be able to do this successfully. We're not saying all of this just to scare you, and we're not saying it all just to sound like it's hopeless. We're going to come back with some strategies, options, potential solutions for you to use that can help you to begin to address some of those gaps. And then finally, at the end of the day, of course, we'll allow for additional questions and answers. So without further ado, I'm going to turn it over to Josh, and he'll start with the triple aim.
Thanks, Megan. So everything that's happening in New York State is happening in the context of what's happening in the federal government. And CMS has established, based on the work that was done at the Institute for Healthcare Improvement, a triple aim to reduce costs, improve quality and outcomes, and improve the experience people have of the healthcare system. To do any one of these things would be incredibly difficult. To do two of them at the same time, to reduce cost and improve quality, would be Herculean. To do all three of them at once is why there is so much going on, is why there is so much effort, so much Sturmendrang, so much underway. Because to try to achieve all three of these things at the same time requires not just a reconceptualization of how the healthcare system works, but a reconceptualization of how the healthcare system fits into the context of the country. And a lot of this is based on information that we have learned about the extent to which the healthcare system, and you see that little thin sliver up in the upper right-hand corner, the healthcare that people receive has about a 10% impact on people's health. What is going on in the rest of the pie chart, what's impacting the rest of people's health outcomes, some of it is about genetics, some of it is about environmental exposure, some of it is about the social circumstances in which people live, and we're going to talk about that in just a minute. But a big chunk of this, 40% of this, is about people's behavior. How many people in this room pay attention to people's behavior? All of us. So what the healthcare system has figured out is that doctors can't fix people's health. Only people can change their own behavior and fix their health. And only people who understand behavior change, only people who understand behavioral impacts and how to help somebody identify what it is that they're doing, what impact it's having on them, and how to change it, that's what's going to enable us to achieve the triple aim. If all we do is fix the healthcare system, we're never going to accomplish all three of these things at once. So right now, what the healthcare system has figured out, finally, is that they need us. This is our moment. This is the moment when all of the jumping up and down and yelling and screaming and waving our arms that we have been doing for decades, those of us who have been toiling in the vineyards of the behavioral healthcare system, all of that is finally coming to fruition because they finally get it. That unless we deal with people from the neck up, we're never going to enable them to change their health outcomes. And so while it might feel like, why is this happening to us and why is this happening to us now? The answer is because we're winning. Because the healthcare system has finally understood that unless they incorporate behavioral healthcare in a meaningful way, unless they really, truly integrate the work that you all do with the work that the medical surgical healthcare system does, they're going to fail. And the people that they serve, who are, let's be clear, the same people as the people that we serve, are going to have bad outcomes. And the people who pay for it are going to have bad outcomes. And we're never going to be able to do these three things unless all of the work that we do gets incorporated into their process. And that's why behavioral health care is being pulled into the mainstream of the healthcare system. And I know it's hard, and I know it's a lot of change, and I know it's a lot to keep track of, but this is what we have been asking for a very long time. And it's our moment now to step up to the plate and to demonstrate that the unique set of skills, the unique set of capabilities, the unique impact of the community-based behavioral healthcare system is absolutely essential to the federal government being able to achieve the, let's be honest, very ambitious goals that it has set out for itself. Now, it's not just us. People have begun to understand the social determinants of health and the impact of financial stability and education and community context and environment in the neighborhood and access to healthcare has on people's ability to be healthy. But let's be clear, we all already knew that, right? It's our service systems that have been building housing. It's our service systems that have been doing vocational rehab. The healthcare system hasn't been housing people unless they were in a hospital. The healthcare system hasn't paid any attention to whether or not somebody has a job or a social safety net. That's us. So what is happening right now is that the healthcare system has finally figured out how desperately they need you, how desperately they need the expertise that you have developed over the last 50 years, how desperately they need us to tell them, to help them, to teach them how to address all of these issues that are going to enable them to achieve their triple aim. At the same time, there is a trend that is happening here where you can see that very quickly, very rapidly, the number of people who are insured in this country by the public healthcare system, by our system, the percentage of people covered by it, the number of people covered by it is growing rapidly. And in short order, it's going to be well over half of the country who gets their health insurance from our system. And so these streams come together. These streams coming together are causing all of this to be happening at once here in our system. And the growth of the system and the growth of the demands on your organizations and the growth of the demands on the relationships that your organizations need to develop, the organizations with which you need to interface, and the people with whom you need to coordinate the care of the people that you serve. Now, here in New York, how is that playing out? Here in New York, that's playing out in the Medicaid Redesign Task Force. And the Medicaid Redesign Task Force looked at the Medicaid system and said, wow, we're spending a ton of money and we're not getting a very good outcome, right? We're not achieving any of the 3 triple aims, right? We're spending a lot of money, we're getting bad outcomes, and people don't experience the care system as being friendly and helpful. So, for better or worse, they are making these changes, and the overarching change that they're making is care management for all. Let's manage everybody's care, and let's manage all of it. Now, heretofore, we have been carved out of that. We've just been in a fee-for-service system. We've been sort of off to the side doing our thing, and it was sort of nice, let's be honest, to be left alone. But as a result, we weren't providing the outcomes that the people we serve need. So while all of this stuff, all of these changes may be a drag, the end result of them is better care for the people that we serve. The end result of them is better outcomes for the people that we serve, is better lives for the people that we serve. And so ultimately, as difficult as it may be, it's all worth it. Because what we're going to be able to do at the end of the day is provide access to better lives for the people that we serve, which I'm sure is why we all got into this business in the first place. If you look at the list of exceptions to the care management for all, they're very small populations. And it's 95% of all the people and 96% of all the money is going to be flowing through managed care. So if you're not in the managed care funds flow, you're not going to get paid. Now, if you've found some angel donor who's going to just dump money on you so you can continue to provide the services that you serve without getting into the managed care funds flow, God bless, you can go home now. But I don't think that's realistic for most of us and most of our organizations. So now the state, and this image is in your charts, and I don't want to get into this because it's incredibly complicated, but the state has a massive, complicated, multi-part plan with lots of moving pieces. And the purpose of putting this up here is not to overwhelm you. The purpose of putting this up here is to say that somewhere here in Albany, there are people who have a sense that all of these things are working together. There are people who have mapped out all of these different initiatives, DSRIP, the SIM, the advanced primary care, health homes, Medicaid managed care, who have mapped them all out and have a sense of all of them hitched to the same wagon, pulling the cart in the same direction. There are a lot of these things going on. If there are acronyms here that you don't recognize, the MCTAC website has a great acronym dictionary. I recommend it very highly. And there are brief in your packets, there are thumbnail sketches of these different initiatives. The point here is, ultimately, there's a whole lot of stuff going on. And, right, Harvey? There's a whole lot of stuff going on, and it's all going on with a single purpose: to enable the people we serve to have better health outcomes and a better experience of the care that we provide at a lower cost to the taxpayers. This is not my image. This image was taken from a presentation that Courtney Burke did. And again, if you don't recognize the acronyms, mctac.org. The point being that the state understands that the work that they're doing here is consistent with, is coordinated with the federal government. Everything is pulling in the same direction. So you can either get on the train or watch it leave the station without you. A lot of folks think, oh, this is like SNPs, it's going to go away. They did this before and it died, and we can just all go back to doing what we were doing before. That's not going to happen, folks. This train is leaving, and we need to figure out how to get on it. Because it's not about us and it's not about the organizations we run. It's about the people we serve and whether or not they're going to get left behind. So we're moving in the behavioral health system. New York State's Medicaid behavioral health system is moving from carved out to carved in. And Megan likes to give me a hard time about my little picture here with the beheaded people. But in some meaningful way, that's what we've been doing. We've been taking care of people from the neck down, and beheading them and putting their heads over in some other system, which is providing services in some other way, which is paid for by a different set of people, which is not coordinated, not organized, and not being done in a manner which is consistent with the healthcare that the rest of them is getting. On just a purely visual basis, you can see that carve-in looks a lot more like people. And ultimately, that's who we're serving. The benefit will include all of the traditional state plan covered services. The behavioral health benefit will be coordinated with medical surgical care. There will be specific, and this is really important, there will be specific behavioral health performance metrics, and there will be a specific behavioral health medical loss ratio in the mainstream managed care plans. This is hugely important protections. The managed care plans can't say, oh yeah, we're gonna give us that money, we'll take care of that too, and then ignore behavioral health care. Because not only are they required to demonstrate that they're producing behavioral health related outcomes, they're also required, and one of the linguistic peculiarities of managed care that after 20 years I still can't quite swallow, is that in a managed care environment, when they provide health care to somebody, that's considered a medical loss. That's money they lost to providing health care. But I'll get to that in just one second. But the behavioral, so the Affordable Care Act, Obamacare, established a cap on, or a minimum medical loss ratio for managed care companies of 85%. Every dollar a managed care company gets now, they have to spend 85% of it providing health care for people. Now, in the carved-in mainstream behavioral health, they're going to have to demonstrate that every dollar they get for behavioral health care, 85% of it is being spent, 85 cents of it is being spent on behavioral health care. So there will still be a separate pool of money identified as behavioral health money, so we don't have to worry that all of our money is just going to get dumped into the healthcare system and people's behavioral health needs and behavioral health spending is going to disappear. So this is Nikki from Phoenix House. Yes, Nikki? Nikki from Phoenix House, and her question was about if the behavioral health benefit is being coordinated with the medical surgical benefit in an organization which is providing both behavioral health and medical surgical care, what will that contract look like? Did I understand that correctly? Okay. It will be up to the individual managed care company whether they want to have a single contract or whether they want to have multiple contracts. My suspicion, my strong expectation, they're just going to want to have one contract. They don't need the administrative headache any more than you all do. Although I don't know for sure, and some managed care companies may choose to keep those contracts separated for whatever administrative reason they have to do so, my expectation is that most will be perfectly happy to have a single contract with Phoenix House whereby they can purchase the entire set of Phoenix House's services. Now, at the same time as this is happening, we're also creating health and recovery plans. And Meg's going to talk a little bit more about what health and recovery plans are and what they consist of and how they're going to function in this context.
So the health and recovery plans, the HARPs, I think there's a couple of elements here that might also further address your question, Nikki, around integration and what this might look like. So there's a couple of different levels of integration, right? There's integration where we think of it, where it really matters, which is at the ground level, interfacing with the individual you're serving, whether they're getting their health and behavioral health care maybe in the same place or at least coordinated through a care manager or some case conferencing or communication between the providers at that level. At the plan level, what they're required to do, what health and recovery plans require them to do is to manage all of those benefits as one plan. So ultimately, you have a plan that's responsible for all the health outcomes and gets that one capitated rate, that one per member per month rate for that individual, and has to cover all their services under that one payment. Now, I think some of what you might be alluding to are the complexities then that some of them have chosen to subcontract with behavioral health organizations who are then specializing in managing some of the behavioral health services on a subcontract. And that's true. But those behavioral health entities are the ones most likely that you're going to have those direct contracts with. And if you're providing integrated care, I believe that I agree with what Josh said, that they haven't come out with clear direction yet for each individual managed care company about what they're going to do. But it is highly unlikely that they're going to want to fracture this even further than because it's not useful or efficient for them as a plan to manage the benefits that way. So just reading some of the tea leaves, we would expect and hope that they would be able to navigate through one contract with each organization as opposed to many. Absolutely, that's a good question. And so through these health and recovery plans, these are for your people that you're serving that currently have the most intensive substance use and mental health diagnoses, issues, functional impairments. And it's going to be determined, their eligibility for these HARPs is going to be determined on a couple of different things. Very first, it's going to be their historic utilization. The state uses an algorithm, it looks at their Medicaid use to date, it looks at what services they've been receiving traditionally, it looks at how many hospitalizations they've had, what intensity level of services they've had, and that's the very first thing that they're going to look at. The second thing they're going to look at is their functional assessment, right? So that the next level of assessing individuals is really going to be conducting those assessments. And as I think many of you have heard, the health home care managers have been identified as those who are going to conduct those assessments. There are pilots happening in some places around the state where they're beginning to try out those assessments and get feedback and to look at how well they're going to work. And then operating the mainstream Medicaid managed care plans, who are not operating those HARPs, who are not serving the absolute most highest need individuals, are now going to be qualified as health plans, and they will provide the state plan services. So even if, let's say, Megan is currently getting her physical health services from Health First or Emblem, one of the major plans in the state, whereas previously I was getting my mental health benefits fee for service if I went for them. I will now, no matter what my eligibility is, I will have those benefits managed completely by that plan that I'm getting. And so there will be an auto-enrollment period in the beginning where individuals are actually just now for some of the downstate regions and will eventually for the upstate regions be getting letters notifying them of that auto-enrollment based on their historical utilization, based on the current plan that they're a part of, and they will be given some options and educate them a little bit about what it looks like to potentially become enrolled in a HARP. And so the enhanced benefit package, the home and community-based services that you all provide that we're going to talk a lot more about today, those are the services that individuals who are HARP eligible will be able to receive and have covered and managed completely in an integrated fashion by their current managed care plan. And so these are the home and community-based services. So this slide is probably one that you've all seen a million times at this point. And I'm going to toggle back and forth a little bit between state plan services, which are those services which are currently required by the New York State Medicaid plan that are covered, that have traditionally been billed fee-for-service. Many of you provide these. They've already been covered by Medicaid for some time. They will continue to be covered by Medicaid, and they will be moved under managed care. You can see that these include inpatient, outpatient clinic, PROS, our IPRT, ACT, assertive community treatment, continuing day treatment, partial hospitalizations, opioid treatment, our outpatient chemical dependency and rehabilitation services. And I would note in particular that mobile crisis services are now tentatively on this list. So as part of the many amendments the state has submitted for approval to CMS, originally, when you saw this slide, in some of the earlier presentations that the state did, you probably saw mobile crisis listed on this slide. Now, since then, that's one of the changes that's been made, actually with a lot of feedback from a lot of individuals in the state, that mobile crisis services, it makes sense, of course, should be available to anyone and not having to determine someone's eligibility for HARPs or home and community-based services before they get a crisis service. Seems to make a lot of sense. And so what they've done is add it back to this proposed list of state plan services. That's still pending approval, but it's expected that ultimately mobile crisis services will be a state plan service as opposed to one of the home and community-based services, which means anybody can get it. So eligibility. I know most of you have heard these things many times, so I'll quickly just touch base, which is that we all know that HARPs are 21 and up, age 21 and up. And that, as I mentioned, there's some auto-enrollment based on that historic utilization and your diagnosis, and also based on now the functional assessment that you've probably heard this term, the Inter-I, which is an internationally recognized assessment tool that's been adapted by New York State for this purpose. If you've been involved in any of those discussions, I've heard from a number of folks, especially some clinicians in the field, that it still needs a little bit of work. I understand that the state has been working with a group of stakeholders, and we know that they've been taking some input, but we also know that, according to many in the field, that it still needs some work to really become the effective and targeted assessment that we would want to determine whether people are eligible for HARPs in New York State. Individuals who are not on these preliminary HARP enrollment lists, they can still be assessed. And of course, HARP members will then subsequently be screened for eligibility for home and community-based services. It's the second tier of screening, and they must meet that they must pass that screening to be determined eligible for home and community-based services. So I just want to be clear that there are two levels of eligibility here. Folks, I think in some cases, we as a community have confounded HARP and HCBS as sort of one and the same. HARP eligibility is one level of assessment. There's some additional assessment necessary to determine eligibility for home and community-based services. And all HARP members will be eligible for health home services. So that's important to note. This is the timeline, and I know, I'm gonna grab the clicker from you. I don't know, I'm sorry that this is a little bit blurry for you to see maybe in the back. What's that? It is, thank you. It's in the packet, so you should have a hard copy in front of you. Only slightly joking, our asterisk in the bottom reminds us all that this is subject to change at any time. This is because obviously we know that we've had many changes to this timeline already. We have the newest dates that are currently available. So the downstate implementation date is January 1 now, 2016. And they have begun this process of distributing letters and enrolling. So I think those folks who are delivering services here around Albany and upstate are going to be looking to see how that process plays out and hopefully staying on target for the implementation dates that you'll see for the rest of the state here. Certainly children's services, we know, are also staggered. They're going to be phased in at a later date. So this is current with everything that the State Department of Health has currently put out. You can sort of walk through. I won't read each individual timeline for notification that's identified there because you have it in front of you. But I would just encourage you to continue to monitor because this has changed many times, and we'll keep it updated on the MCTAC website as I have heard of changes as well. All right, we're going to jump into the foundational elements of managed care. So we're going to go over a little bit of the utilization review and utilization management terms, the authorization process that managed care uses. We're going to cover the payment constructs, some of the value-based payment models that you may have heard of, because we have to remember that this initial 2-year period of navigating managed care is going to be essentially still a fee-for-service structure with state-established rates, but down the road, the ultimate goal is going to be to move to a risk-based payment structure with managed care, and we'll talk a little bit about that. We're also going to talk briefly about contracting and get into QI and QA, and then, of course, talking a little bit about credentialing and MPI. And so does everyone in this room have an MPI already, or who has an MPI already? Ooh, a lot of you. More, I think a little bit more than we had in Syracuse. For those of you who don't, we actually do have a federal letter that's addressed to providers that walks you through the steps of how you register for that. We're happy to share that with you if it's useful. But that's one of the very first steps that anyone should undertake if you're planning on starting to bill Medicaid managed care and haven't yet. So utilization management versus utilization review. I have to say that we cover this here at a high level, and I'm going to talk a little bit about these two concepts. But MCTAC also has a fabulous detailed UR and UM training and a PowerPoint on their website that will get into it a little bit more in depth than we can do in the amount of time we have today. I would encourage you to go to that site. There are a number of these topics where they dive more deeply into an individual topic, and they'll have longer trainings coming up throughout the summer and the coming months on some of these in addition. But utilization review. So many folks think of utilization review because it's regulatorily mandated for places like hospitals and many licensed treatment facilities that you must review in an ongoing way with some frequency open cases that you have. It's a requirement that you're evaluating whether the services the individual is getting are medically necessary, that they're in the actual lowest level of care that the individual can possibly receive. The most integrated setting is the term we frequently use in our world, of course. That it's not just at the convenience of the individual or the provider, that we don't let services just continue sort of indefinitely on because that's what the individual has always been getting, and so they keep getting it and not evaluating whether in fact it's still what's needed, whether any changes are needed to that care plan, whether they should really be getting a lower level of care, maybe step down into less intensive services. And this is really about managing the individual's needs and making sure the services are reactive and customized to an individual and not just sort of a cookie cutter, maybe standardized way of delivering services where we're giving everybody the same level of care regardless of that individual need. And the utilization management really is a larger and systemic process for managed care of establishing that the services, in addition to being medically necessary for that individual, are cost effective, that they have a rationale behind them. When I talk about utilization management and review, a lot of times with providers, I get a lot of frustration from them that this is just another way of managed care to keep their costs down, to tell us no, to cut off services, to deny people what they need. And we've been doing this for a long time. We know what we're doing. We know what the people we're serving need. Why do we have to go through this? Sometimes managed care uses these rather standardized algorithms to arrive at these decisions. And so it seems like they're maybe a little bit impersonal or that they don't pay enough attention to an individual's needs. But first of all, the thing about managed care is they're making a lot of these decisions on a very large volume, a very massive scale. So some standardization is absolutely necessary for them to do so in an efficient way. What I usually tell providers is their decision, when they conduct their review and they challenge you or maybe deny or don't authorize a service that you think is appropriate, that is the beginning of the conversation. And we hear from them all the time that, managed care on the other side says, well, providers complain that we deny things or they don't understand or that we're not authorizing, but they don't pick up the phone and call us. And so the expectation, of course, is that at some threshold, they have to standardize their decision-making for authorization of services. We understand that. That's just a pure scale issue. But at the next level, they expect it to be a conversation between you and between them, and you become what you've been in many, many cases for a long time with these individuals, the first line of defense, the first level of advocacy for the individual you're serving. What they're mostly looking for when I hear from people at the plan side, when they're talking about negotiating around particularly decisions of authorizing services, they want to hear from you an understanding and a rationale for why that service is important to that individual at that time. That you have thought it through, that you have a clearly articulated, if there's an evidence base to the service that they need to get, that's always the sort of holy grail that you can make that argument. If you have any data about the individual, what their progress has been, understanding when you call them the individual's history and trajectory, and just being able to explain to them why this service maybe needs to continue beyond the original limits of that service, or beyond what was originally put in that treatment plan. But it can be a conversation. And it's not necessarily a challenge to the provider's individual expertise. It's just that they need to have a way to rationalize and to justify why that individual is getting that care, because they have to manage the costs. They have to make sure it's the most appropriate service that the individual is eligible for. That's part of their job. They're required to do that. So in thinking about when you get these decisions, I understand it can be very frustrating. It can feel like arbitrary, maybe. But you are the expert. You as the provider have the ability to make that argument with the managed care company, and building relationships. We're going to talk a little bit more about the communication strategies with plans, building those relationships and knowing who at the plan you can go to when you need to, and really beginning to work up that, that shared language. That vocabulary is definitely a step in the direction of being able to partner together around the care the individuals you serve need. Because in the ideal world, it, of course, is a partnership. I recognize that it doesn't always play out that way in the real world. So when they do their authorization check, they have to go through a couple of key things. They have to look at whether the individual is eligible, pure and simple. I have heard about a lot of providers out there, in particular during our adult health home implementation in New York State, where they ultimately lost a lot of revenue because they didn't do the most basic thing, which is to check at the very beginning whether the individual was eligible, enrolled, and had their Medicaid in place. And then ultimately, they were denied reimbursement. That, if that doesn't happen, that's the very first step, and there's nothing you can do about it. I'm sorry, there's a question in the back?
I'm presuming that some of the people that we're talking about will not have a readily available treatment history and will not be enrolled. So can you walk us back through that process that would lead to them joining the system, so to speak?
Okay, so it sounds like some of what you're asking, so some individuals will not have a readily available treatment history or will not be enrolled when they present to you for services. And so what do we do with those folks in that very first initial step? So if they're referred to you, I mean, the first thing, and I think many of you are doing this right now, you're first trying to verify if they have any insurance in place or connecting them, hopefully, to a care coordinator who does some facilitated enrollment with Medicaid and determines their eligibility. Those still remain the initial steps. Now, if an individual is not eligible at all, then quite frankly, they're in a separate subset of individuals who will not be covered by what we're talking about here today, because we are talking about Medicaid services. We are talking about services for individuals only who are Medicaid eligible and enrolled. Now, for health home care coordinators, there is a process that they can pursue where they can, in the initial month when they get a referral, they can begin to coordinate care and facilitate that enrollment in Medicaid, and ultimately, once the individual is enrolled, they'll get reimbursed. Also, they are still receiving a small amount of dollars that are for non-Medicaid individuals. So if an individual ultimately is not Medicaid eligible, there are some services that will need to continue to get funding outside of Medicaid, and the state is aware of this. And those individuals will have to be covered out of a separate pool, but they will not be covered by this set of services, or these managed care companies are enrolled in HARPs. Sorry, go ahead.
I'm a program manager, and I have a provider calls me and says, we've had some difficulty. We have a client who is critical care, pancreatitis. We have a bed waiting. Insurance provider is denying that, saying no. In the meantime, you're asking for this conversation to go back and forth. Well, there was about a week elapsed because of everybody trying to get, the client is now missing. We had a bed, we had everything ready to go. This is where it becomes critical, where these are lives. These are people's lives, and it's wonderful to have this development and this back and forth conversation. But what about those instances where we have a client, he's sitting at our desk, we have a bed available, we don't get him, he may die or she may die. What do we do?
Yeah. It's a terrible situation.
And the question came up, can we just put him in the bed? And we know that they're now required during the appeal process to pay. Can we do that in that circumstance? Because it was a denial before he got into treatment. Can we put him in that bed?
Sure. So, I mean, a couple of things. This is a very detailed example. I'll cover a little bit of a high-level response, and then just also say that many of these appeals processes are still being developed. So not every answer is available today, and we know that. But absolutely, there are timeliness requirements that are absolutely focused both on crisis services and non-crisis services. And managed care has an obligation to respond within a very limited amount of time. And for a crisis service, generally, they are not allowed to require authorization in initially, and that crisis service can be provided without that authorization. And then ultimately, yes, there is a negotiation and appeals process that you would go through. The unfortunate thing is that sometimes you're going to provide services and they're going to be denied. You have an outlet to you, and there is an assumption built into this system that there's some rate of denial. And unfortunately, when you do your projections, that has to be a part of your calculations. So there's sort of a multifaceted response to that. Some is that first, there's very strict requirements on managed care for their responsiveness to you, and they absolutely have to be responding in those tight timeframes. Second, if they don't, and there's a true determined crisis, medical or otherwise, as you go ahead and provide the service, and ultimately you will have a process to go through to identify and get that reimbursement. And third, unfortunately, there may be times you're not 100% of the time going to get that reimbursement, and thinking through how to incorporate that into your financial projections is a part of this process in this system. Do I see a hand over here?
This is not, what I'm going to say is not necessarily going to help in the moment, but not only that there will be, I believe, an increased ombuds function for the beneficiary, so it won't help right in the moment where you're trying to get hospitalized, but if you're generally unhappy with your plan, or you feel like in certain instances they're not responding, there will be more ombuds workers, right?
Yes, absolutely. That's a great point. So a little bit later when we talk about communication strategies with managed care, there's actually a requirement in the RFQ that there is I'm going to get the acronym wrong, sorry, Behavioral Health Service Center that is required that any managed care who qualifies to do a HARP or be qualified to manage behavioral health services has to have a 24-hour behavioral health service center that you can call. That should improve access. We realize that's in theory right now, and how that operationalizes, I can't predict the future either, but that is a requirement within the RFQ, and we cover that a little bit more later. This is the checklist that I was referring to when managed care goes through. They do have to have some sort of standardized process for authorization that they start with. Individuals eligible, they must be approved for that service. We're going to hit this over and over again throughout the day, that the care plan is king. In order for services to be authorized and eligible, they must be reflected in an individual's care plan, that service for that individual. So that's very, very important. They must be the most appropriate. This is this determination around level of care. So if they can be served safely in the community, in a respite, in an outpatient program, they're not going to approve a hospitalization. That at the very basic level. That they must be provided within the timeliness standards that I mentioned. For many services, it's going to be 72 hours for managed care that they have to turn that authorization around. Crisis services have a different construct, and we can pull that information and share the details around that, and that's going to be also available in the RFQ. There's very specific requirements that they have to respond to, that they meet medically necessary criteria, which means that not getting the service is going to have an impact on the individual's health, wellness, recovery, that there's some negative impact that can be demonstrated if they don't get the service. And then in line with best practice guidelines, this is where relying on fidelity to the evidence-based practices that are out there, like supported employment, are very, very helpful to you in making your case with managed care. If you're using evidence-based practices in your program already, just doing an evaluation and making sure you're following those models, and when you can articulate that, that helps make your case for your service necessity. I'm sorry, Nikki, did you have another one?
Yeah. So I'm usually a very positive person, but this is really giving me great angst. Only because, like, when you go through the authorization checklist and you say meets medically necessary criteria. In the health world, you go to the cms.gov website, you put in a CPT code or something, and it comes up, voila, all the diagnoses that you possibly get covered by this. Is all of that going to be ready by October?
It's a great question. So the date is in October. I think you have October in your mind for something. There's
for the managed. That's what. Oh,
so,
yes. Sorry.
Okay. I'm sorry. Okay, I understand. And it's technically now even the enrollment process, the auto enrollment process for individuals starting in October, but the actual implementation date, the sort of go live is January 1. Just to be real clear for you on that. But I understand your concern about medical necessity. So. Not getting in the weeds too much on this, and I'm happy to follow up with you offline, but CMS did just release updated proposed rules and regulations governing managed care, and one of the requirements is that that states have to provide the criteria around medical necessity upon request. And so that isn't regulation yet, but it's proposed regulation. That they're going to have to issue standard definitions and be able to provide that to you as a provider. So just hang tight on that. All right. So this is a very basic, as you indicated, a basic definition. You can see that is much more geared towards medical services than the sort of traditional home and community-based paradigm that we all work within. But very specifically within the proposed rule that CMS has recently released, they address medical necessity for people with mental health and substance use issues. So there will be further standardized guidance that will be required to be provided to providers as part of that rule. Health homes. Health homes as the cornerstone of access for people now in the system as far as home and community-based services. So I think it's really important that we just emphasize, if you're not in a health home already, if you haven't made those health home connections, if you aren't part of a network, if you aren't talking actively and proactively with the health homes in your region, today is the day to start. It's very important because they have to know who you are. They have to be working with you. If they're assessing individuals and helping to develop that care plan, they should be doing so in conjunction with you who are serving that individual. And so you should be able to provide insight and input into that care plan. Now, I know we're a ways off from that. I know the health home implementation has been bumpy, and I know that on the ground, that's not quite happening yet. But I think it's very important because health homes are not going away. I think a lot of people cross their fingers and hope that they would either speed up really quickly or sort of fade away into the distance, and they're not going anywhere. They are one of the foundations that this transformation has been built on. And so those care coordinators being able to accurately assess the people that they're serving and work with you to manage those care plans is a really, really important part of this, and that is going to require proactive communication from all of you to them. And I've never heard of someone I've never heard of a mean health home where someone called them up and said, we want to be part of your network and work with you, and they said, no, absolutely not, we won't. There might be one out there, but I haven't heard of that yet. So in general, the health homes are very receptive. They want to have as broad a network as they possibly can. So just encourage that proactive outreach. And these are the managed care priorities. And the reason why I talk about these is because I like to just sort of remind us all that the people who work with, they're people too. They work within the people who are working within managed care organizations are human beings, and many of them were providers at one point, and they're coming from a perspective of they have a ton of oversight on them, and what they're doing is not just to make your lives difficult. Just as a reminder that you can have a conversation with them, that you can engage with them on these issues. But these are the things that matter to them, that are essentially inherent in the charge of managed care, which are quality. None of these things in and of themselves are necessarily bad things. We recognize they can be perceived as incredibly burdensome to providers, but in and of themselves, they're concepts that are important to improving the overall care that people are getting. Quality monitoring and reporting, improving health outcomes, and timely access to care. One of their key responsibilities is to build adequate networks of providers, including now home and community-based service providers. They need you. They are going to be required by the state in order to keep their contracts and keep doing this work, that they have an adequate network so that when people in their plan, who are enrolled in their plan, need home and community-based services, they can get the access they need. And so they need you. They have not traditionally, many of them, actually built networks of home and community-based services, so this is a mutual education process between you and them. Managing costs. You saw the chart that Josh showed in the very beginning, those skyrocketing bar charts where we're going to have over 56% of individuals in this country by 2024 enrolled in one of these major programs. It's important to the future economics and success of this country that we manage the costs of these programs and that they're managed efficiently. It's just, there's no way around it. It's not that people are just trying to save a dollar. The authorization process, we talked about why it's important. And then customer service. One of the things that is really important is this notion of customer service. That side of the triple aim that Josh referenced on one of the arrows on the target was the experience of individuals getting healthcare, which in fact frequently then drives their participation and engagement in the system. If they're not having a good experience, they're not getting customer service both from you and from their managed care plans, that's a problem because it's probably going to affect what kind of, whether they go for that checkup or get that service that they need. Level of care criteria. So this is, oh, I'm sorry, there's a question in the back.
For services.
So
Say, okay, they deem the criteria for services. Could the managed care organization that say, well, we're not ready to pay for it, or we don't feel that way, and we're going to appeal that decision?
So as I understand it, yes, there will be a process for negotiating that. It's and as a provider, you could also challenge the health home's assessment or request a review or appeal of that process, but the details of that have not been released, so I don't know what that's going to look like exactly. But theoretically, anyone could appeal that process.
They have to authorize services just because the health home is certified.
Managed care must approve the care plan that the health home has created, the care coordinator out of the health home has created. So I don't know that the managed care company can challenge the assessment, but I know that they can engage, and they ultimately have to approve the plan of care, which then delineates each of the services that the individual is supposed to get.
Something along the same lines, will a provider have the flexibility of leaving a managed care organization in favor of another one if they deem that necessary based on maybe the number of denials, the number of can they do that?
Ultimately, you can make a decision about who you do business with. There are a lot of implications for that decision and for the people you serve, which are complex. Which, if we can maybe get back to them in a little bit, your decisions about who you do business with, which managed care plans. I think we'll try to get back to that.
Okay.
All right, contracting, and this is another one where just very high level, we're going to touch through the key terms that you should be paying attention to in a managed care contract. I've heard from many folks that they're already getting contracts from managed care. They're being sent them. I know that managed care right now is tending to use some very boilerplate language. These are the kinds of things you're going to see in that boilerplate language. Key terms are the parties and definitions of the terms in the contract. Become familiar just with each of these sections of a managed care contract and what it might include. And I don't know how to emphasize enough that a really good lawyer is an incredibly valuable tool in this process, because don't just, if Beacon or Optum or somebody sends you a contract, don't just sign it off the bat. They may be pushing these standard boilerplate terms, but make sure that you're reviewing it, that you know what you're agreeing to, you know what's required of you. It's just incredibly important that each of these be very clear to you. They're going to talk about access. They may have requirements about hours of access. They're going to talk about dispute resolution or litigation. These issues are important for your lawyer to be very clear and to be talking with their lawyers to make sure that the division of liability is very explicit and that everybody understands what the implications of that are. The audit and monitoring and oversight functions, what they're going to do to ensure compliance with that contract. If they're going to be coming out and doing any kind of auditing or oversight of you, you should be very, very clear on what those requirements are. So I would encourage you to go to the MCTAC website. They have a lengthy, detailed contracting training that they have done, and those materials are on their website, and they get into much more detail about each of these individual sections and provisions of a managed care contract. Financing model. So we've talked a little bit in other settings about the potential for future risk sharing between providers and managed care. And again, that's a whole session in and of itself, but I'm just going to take a second and point out the various terms that you may hear around financing models. We know that even above that fee for service, many of you currently have cost-based contracts directly with government where you're getting grant funds, you have a budget, you're reimbursed based on quarterly claims that you submit that say, I spent this much money on staffing and stuff this month or this quarter, and so pay me, and you have to meet some levels of service. Then you have your fee for service, which many of you are currently doing for your outpatient services if you deliver them. Medical home, there's many terms. You'll hear a lot of different variations on a theme, whether it's a health home or a patient-centered medical home, this is essentially an enhanced set of requirements that an individual practice or provider is required to meet in order to get either some kind of enhanced rate or potential incentive payments for quality standards that they meet. This is around a more coordinated, integrated, and having an individual who's accepted accountability for an individual's care. We have pay for performance, which some of you probably in some realm, way, shape, or form have already received. If you've ever made an agreement through a grant program or a contract that if you meet certain standards above and beyond your baseline of covering your costs, that you would get additional payments, then you've had to pay for performance. A bundled rate, this is something not used quite so frequently in our system yet, certainly used sometimes in the healthcare world, where it's frequently used for an episode of care or some longer term or period for an individual who has a particular diagnosis or a condition over a period of time, and it can encompass a number of services, perhaps that individual needs to get, some outpatient, some inpatient, some rehab services, all for that one episode of care that they require. Shared savings, up and down. You may be hearing about upside risk and downside risk out there. Upside risk is basically where you have an agreement with a managed care company that if they save money and you help them by achieving some either really good outcomes for individuals such that their utilization is going down over time and they're not costing the system or the managed care company as much, if they save money, you share some of that savings, and there's different ways and arrangements to do that. Downside risk probably seems obvious, the counter of that. The only thing I usually say in these seems fairly obvious, but never take downside risk without upside risk also. And there are ways to actually negotiate upside risk without downside risk. Believe it or not, there are many times when managed care may be interested in doing so, because I say this to folks all the time, and I don't know if people believe me, but I'll say it to you again anyway, which is that they need you. They have requirements. They have this medical loss ratio. They have this per member per month. They have to keep the costs down under those amounts, or they essentially lose money. They also need you because more and more the feds and the states are requiring them to achieve quality standards, and if they don't do that, they lose money, or they don't get all the money that they're potentially entitled for. They need you. They actually can't do that all by themselves. There are a whole lot of protections that say they can't just say no to everybody and say nobody gets any service and so I save money. They actually have to achieve these standards and quality outcomes. Without you, they can't do that. So ultimately, thinking about how you might share, if you're doing your job and doing a good job of it and sharing that risk, upside risk or savings with the managed care, that's where we need to be looking down the line as a system. And then I think partial capitation is where many of us are right now, or where we're about to be, which is just that some services are being managed out of a per member per month, like physical health care has been, and some services are continuing to be paid fee for service, like the behavioral health has. And you can imagine full capitation is everything, every single service that an individual ever needs under one rate. And this is just a picture that I use that shows very clearly that the more risk you're willing to take on and the more accountability that you take on as a provider, the greater potential that you have both to share in the gains, but also in the risk. So as that accountability on the y-axis is going up, that financial risk is going up also. Potential benefits and potential risk both increasing. So very, very quickly, with access, what we're talking about is the access of individuals to get into your services in a very timely way in our system traditionally, because we've had, this is the capacity. We have a cost-based budget that's capped, and you can't add more, and you can't grow, you can't expand, you can't add more staff, even if you want to, because no one's going to pay for them. That's changing, and so the ability for individuals to get access in a timely way is an important requirement of managed care. They're going to require that people not sit on a waiting list. They're going to have timely access standards, and knowing those when you sign those managed care contracts will be very important. And then I mentioned very briefly communicating with the plans. Very important to consider them as a partner, very important to proactively outreach. Someone asked a little bit earlier about denial rates. If someone's denying one of the plans that you're working with, can you just walk away? Well, sure you can. It's a business arrangement. As I said, there are a lot of implications about whether you can continue providing the services to the people who are enrolled in that plan who come to your program and whether you get paid for them. But ultimately, if you're getting denied a lot by one plan, you should be first reaching out to the plan early and often. And second, you should be reaching out to the state, working with your state partners who will have a process, and they need to hear from you early and often. You should have in your organization a liaison, a person whose job it is to be thinking about communicating and beginning to communicate with the plans, who knows who the key contacts are at every plan that you're doing business with, who knows how to get a hold of people. This is a key function within your organization. Someone needs to know who to call, right? We all know that it's very relational, no matter how much we try to make it more standardized. Somebody in your agency should know that, yes.
Can you help me on how I could convince my executive director of this? We've specifically already been told we need to do this the least expensive way possible as we get into all of this.
We're going to actually go around and happy to talk to any individual agency. Each agency is unique and may have different constraints and parameters, so happy to absolutely talk with anybody on breaks. And this is the Behavioral Health Service Center that I mentioned just briefly. They will be required by the RFQ to have these in order to be deemed ready to manage behavioral health services. And so these are the things that they must be able to address at that 24-hour service center. Each managed care organization must have one of these. So become acquainted with yours. That should be a point of access for you and for your staff, really, to begin to develop those relationships to get the answers you need. Have a plan within your organization about how to address it. It's important that it just be a conversation and a part of your strategic planning and not just be haphazard. And there are tools that we can help you identify to do that even more. We're going to talk about that planning. So we are going to start an exercise, and we're going to use your packets. And I think, Josh, you're going to lead us through the PPI exercise. You should be able to find in the handouts on your table. I don't know what page it is, I'm sorry.
So rather than ask you all to talk about your own agencies, we know sometimes it's a little easier to have a conversation in public about a more abstract construct. So we created an agency, just to be clear. I made this agency up. If it's your agency, wow, that's weird. And so if you look in your packets, you'll find a page here. It's titled Peer Provider Inc. We didn't spend a lot of time making up the name. And Peer Provider Inc. is a sort of an archetypal sample of an agency. It's located in Cohoes, so it doesn't have a lot of competition. They're a 501c3, started by peers, run by peers, always have been run by peers. They have a psychosocial club. They provide some supported employment and supported housing, supported education, and some substance use peer support, funded through a variety of grants from OMH and OASAS. They do require a couple $100,000 of raised funds. They have a big gala every year in order to make the budget work out. They're living with a budget right now of about $2.5 million. They applied for and were designated to provide a pretty broad range of HCBS services. So the question for you all is, if you were the executive team at PPI, if you were a part of the PPI leadership, what are the first couple of things you need to be doing to get ready? This is coming. You've been approved. Now what? So take a couple of minutes, talk to the folks at your tables, make some friends, unless you brought your friends with you. Talk to the folks at your tables, take a couple of minutes to talk about what are the first couple of things that PPI needs to be working on. If y'all take maybe 3 to 5 minutes to talk to each other, then we'll come back together and share. Thanks.